So welcome everyone to the Society of Thoracic Surgeons. Today is Wednesday, March 11th. Welcome to our General Thoracic Surgery Database monthly webinar. We'll go ahead and get started with our agenda again, same as usual. I'll just provide a couple of a super brief STS update, and then we'll hop into our data manager education. We've got some harvest close. I'm going to do a harvest close review, and then Ruth is just going to give a couple of training manual updates. We're going to switch the order of those as Ruth may have to jump off a little bit early today. So we're going to flip-flop which one goes first there. And then we'll finish things up with our Q&A. On the call with me today from the STS side, we have myself, Emily Conrad, Nancy Honeycutt, Banu Yatsi, Kate Barna, Paul Meehan, Sydney Clinton, and our GTSD consultant, Ruth. So thanks everyone for being on. All right, so let's go ahead and hop into our STS update. Just a reminder, if you do not make it a habit of doing so, please just a reminder to check those IQVIA notifications once you log into the platform. We did just have a new notification posted. We had a release over this past weekend. So there is a notification that does outline the items that were released over this past weekend. So we do have a few data quality report enhancements. I'm not going to go into a lot of detail and read through each and every one of these, but just to highlight some, we added upload ID, date and time, updated the duplicate filter. It's now renamed from duplicate to status. So now you will see the filter options under status. We have new, which displays all newly added records. We have updated, displays all existing records that have been modified. Not updated, which displays all of the existing records that were re-uploaded but have no changes. And then we have deleted, which displays all records that have been deleted. And then we also added a warning message to the DQR when a record is deleted from the IQVIA system. So hopefully those new enhancements will be helpful. Also, we updated was that twice? Yeah, that's listed twice. I don't know why that's listed twice there. And then we have a DDR, direct data report enhancement for those direct data entry specific participants, the ability to populate HOSP name and HOSP NPI fields in the data download report for those direct data entry sites. If you have any questions about these enhancements or new enhancements to the filters, please reach out to the help desk, and Paul and Banu and our team can help you navigate through and understand those new filters if you have any questions, or updated filters, enhanced filters rather. Next, as you all are very much aware, our spring 2026 harvest closes this Friday. Harvest submission in the last time to submit a file for the spring 2026 harvest is this Friday at 11:59 p.m. Eastern time. So please note, it is 11:59 p.m. Eastern time. For those of you on the West Coast, please keep that in mind, and other time zones. As always, we strongly encourage you not to wait till Friday to submit your last file, or Friday at 11:58 p.m. Eastern time to submit that last file. Inevitably, something always goes wrong. So again, please get those files in as soon as you can this week. The last day to opt out of the harvest is March 17th. And just a reminder that this harvest analytical period will include procedures performed up through December 31st of 2025. So the analytical period will include January 1, 2023 through December 31st, 2025. Our fall 26 harvest, mark your calendar, is scheduled to close on September 18th. So keep that in mind. All right, AQO reminders. Again, September AQO 2026 will be held in New Orleans and is scheduled for September 30th through October the 2nd. Our GTSD session will be held September the 30th with a full day and then a half day on October 1st. Intermax PDMax will have a live virtual forum on September the 24th. And then our ACSD sessions will be held October 1st and 2nd. Those half-day sessions will be small group discussions as opposed to a standard session. So there will not be like a microphone, slides, etc. It will not be a formal session. It's also important to note for those of you attending AQO, these breakout discussions will not be recorded, meaning that our virtual attendees will not have access to these breakout discussions. For our in-person attendees, just note that you will be able to select which topics you would like to, which discussions you would like to attend on the day of the event. So we'll have more information coming about registration, selection of the sessions you'd like to attend. So more information about pricing, registration, all of that will be coming here soon. Also, there is a link here to our AQO 2026 session proposal form. The deadline for that session proposal form is April the 3rd. So if you have something that you would like to perhaps present at AQO this year, or a session that you know of someone who would be a good speaker for or would be a good topic to cover, please fill out that AQO session proposal form. We will use those when we are starting to, here in the next couple of weeks, when we start to plan the sessions for this year's AQO. Our abstract submission form has now been posted out on the STS website as of about 15-20 minutes ago, Emily just told me. So we do have a link to our abstract submission form here, and then the deadline for abstract submissions is June the 12th. So we would love to have some GTSD abstracts again this year. I know we had several last year. We would love to continue that again in 2026 and have you submit an abstract for this year. So the guidelines, again, are also posted out there with this submission form, so all of the information can be found via this link for the abstract submission form. Anything I left out, Emily?
Nope, that looks good.
Nope. All right, great. So let us know if you have any questions about AQL. All right, for our STS education, as I stated, I'm going to turn things over to Ruth because she may have to dip out a little early. So let me get to her slide. She's got some training manual review. And with that being said, the GTSD and also if you're a CHSD site, those training manuals should be posted today. So we'll be on the lookout for the updated GTSD and CHSD. If you're a CHSD participant, this training manual should be available today. All right, Ruth, I'll let you take over from here.
Thanks, Leanne. So just a few updates from the training manual. Like she said, sequence 970 is the first sequence with an update. So for patients who receive neoadjuvant daily oral therapies, data managers will need to determine the number of days of oral treatment that are part of a cycle in order to code sequence 970. We don't want people to default to coding 5 or more in instances where patients are receiving daily oral neoadjuvant therapy unless 5 or more cycles were truly administered based on the documented cycle length that you can find. If you can't figure out how many days of a daily oral neoadjuvant treatment therapy equal 1 cycle, then you can code unknown. But please do attempt to figure this out on your own. Don't default to coding all of these as unknown. And then there's an example here. So a patient received alectinib for 44 days. The last day was 12/2. The surgery date was 1/15. A cycle is 4 weeks. Oh, well, something weird happened with my link when it moved over, but a cycle is 4 weeks. The patient completed 1.5 cycles, and for some reason, the link is embedded in the middle of my sentence. But hopefully that'll be clear enough. Maybe we can edit it before we post it.
Yeah,
sorry about
yeah,
that.
I'll get it edited before I send it over for posting.
Thanks. If you want to go to the next slide, please. This is a huge change, and so I want to spend a little bit of time on this. So we are very intentionally changing sequence 1810 to align with data being collected in sequence 1800, which is lung cancer tumor size in the new temporary date field. The STS is very interested, and for those of you who heard Dr. Vallada, very passionate about using this data to determine impact of delay to surgery on patients' disease progression. So clinical T stage should no longer be assigned based on documentation in the medical record provided by your oncologist or your surgeon. We had been working for the last 3 years to try to get your surgeons or oncologists to document in the record for you to be able to abstract it. You don't have to undo that. It's fine if they want to document it for their purposes. I think Commission on Cancer requires that it be documented in the chart somewhere anyway, so I would just leave that alone. But now what we would like for you to do is for you to determine the patient's clinical T stage and in clinical N as well, I guess, if that would be relevant, based on the tipping point CT that was used for coding sequence 1800, which is not necessarily the CT closest to surgery. If your patient only had one CT prior to surgery, like if your tipping point CT is the CT closest to surgery, it's going to be a little bit less complicated for you, obviously, because you're not going to have to go through the thought exercise of trying to figure out which one is your tipping point CT. But then you're going to use the information in the training manual to code clinical T stage, which might be different than what your surgeon or oncologist documented. If a CT scan from an outside institution is the tipping point CT that yielded a referral to your institution, that CT must be used to document clinical T stage, as well as the information coded in 1800 in the temporary date field. The STS intentionally does not want to capture clinical T stage only from imaging obtained from your site. So you'll need to do a little bit of a broader search, as we discussed previously. I, again, know that this is a big change, but I'm hopeful that it'll be fairly straightforward since you're now using the same CT for clinical T 1800 and the temp date field. Want to go to the next slide, please. Sequence 2111, distance from invasive carcinoma to closest margin. We should have probably included a not applicable or not available option here, but we did not. So if margins are positive, you're going to code 0 for sequence 2111. Because there's no distance from invasive carcinoma to the closest margin because your margin's positive. And if there's no residual tumor in the pathology specimen for a therapeutic resection, then you're going to leave 2111 blank. Next slide. We updated sequence 3840 discharge on anticoagulation to match the pre-op therapeutic anticoagulation sequence. So now if a patient is discharged from the index admission on aspirin, inclusive of baby aspirin for treatment of a new atrial arrhythmia, you're going to code yes to 3840. So we've lined through, when you see the training manual published, we've lined through where it says to exclude aspirin up in the intent clarification, and then added this FAQ to say that aspirin would be collected. The same principles apply that are up in the already existing intent clarification. If your patient was on aspirin pre-op and the intention was to discharge them on that aspirin post-op, you would not code yes because it's not a new treatment for a new atrial arrhythmia. It's the same treatment. So, and then there is a parent to this sequence as well. So that would limit the number of, appropriately limit coding for sequence 3840. And I think that is oh, sorry, I forgot about synchronous primaries, my favorite topic. Only one data collection form can be completed for an encounter to the OR across all encounters to the OR. So if your patient has an esophagectomy and a lung resection in the same trip to the OR, you're going to put that on one data collection form. And then that's when you use the weighting to determine like what your primary procedure is going to be. This was all carried over from version 5.21, not a change. If 2 or more tumors are resected during the same procedure, you're going to code the most aggressive disease noted on the pathology report. You might have to talk to your pathologist if you're not able to determine that on your own. Really, there's not any changes between the way we coded synchronous primaries in the previous version versus this version, except we added a sequence to capture whether your patient did have synchronous primaries or not. But you still can only, like if there's two pathological stages, because for your synchronous primaries, you still are only going to be able to enter one. The SES we discussed, and there was like no interest in collecting separate pathology for multiple tumors. So that's why we chose to go that direction. So there, again, like really no change here except for the addition of one field related to synchronous primaries. That doesn't change the way you abstract the remainder of the case.
I don't know how you are on time, Ruth. Did you want to tackle questions now and then we go over harvest close stuff, or how do you want to, what works best for you?
Sure, I can do some questions. Thanks.
Okay.
I appreciate the flexibility.
No problem.
There's a couple questions about direct data entry that I'm going to skip over and leave
Yeah,
those for
that's
you
fine.
or Paul or Bono. Quick question regarding wedge resections. I had a case where the surgeon did a wedge resection for bleeding. How would you code this? First of all, you do not have to enter that case. If you choose to enter that case, I've resected those as therapeutic wedge resections because it's treating the bleeding. However, it's not going to be a lung cancer case, so it's going to get thrown out of your analysis based on the fact that you say lung cancer, no. And then, of course, your primary category of disease would also throw the case out because your primary category of disease is not going to be lung cancer. So, again, you can, if you're choosing to enter it, it's really for your sites, only for the purpose of your site. Sequence 1621, if we have two PET scans, should we take the SUV max from? Let me grab the training manual. Um,
Um, see,
Winnie, I don't think we've clarified that yet, so I will find that out and add it in. I assume you've already sent it in as an FAQ, which means you'll probably see it when we meet as a core group this week on Friday. Can we use low-dose CT to determine tumor size and date? If yes, the patient had a lung cancer, a low-dose CT and PET scan. Low-dose CT doesn't show the solid component, but the PET scan does. Do we still enter the low-dose CT value because it was done before the PET? Yes, you can use low-dose CT to determine tumor size, and that would be your tipping point CTE date. If the low-dose CT does not show a solid component, I would confirm that truly there was no solid component visible on that low-dose CT. And if so, then I would enter the information, based off of the low-dose CT as directed in the training manual. What if the nodule in the PET scan is not hypermetabolic with no SUV max? Do we leave the SUV max blank or enter 0? Please enter 0. Laura asked about non-mucinous adenocarcinomas that are complex glandular. It's in the March training manual for you, Laura. You would just leave it blank. How do we capture PD-L1 when it is reported as negative, positive? This field requires a number value. Oh, I see. I do not recall if we have ever assigned numerical values to negative and positive. I assume not because we didn't carry it over from the previous training manual, but I will double check that, Christina, and then get back to you on that question. If you haven't already submitted as an FAQ, please do.
Yeah, I don't remember that either. I'll look at it as well.
Thanks.
Mhm.
For esophageal cases, MSI and HER2, can that only be taken from the prior pathology, or or from final path, or is prior pathology okay? Let me just,
Um,
I would assume that prior pathology is going to be okay, but oh, sorry, my computer is laggy. Oh, we say to use the final pathology report from specimens collected during the current surgery, specifically in the training manual. So I assume that the surgeons had a great reason for that. I can ask them what their logic behind that was, like why they only wanted final pathology reports from specimens collected during the current surgery. I don't recall the logic behind that off the top of my head, but it is specifically addressed. If a patient has two cancers, sorry, the question moved while I was partway through reading it.
yeah.
If a patient has two cancers, is there nowhere to mark it now? Um, not sure what you mean, but you should be able to record. You should be able to record the cancer types. I mean, we did get rid of the pre-existing or like coexisting cancer. That was intentionally removed if that's what you're referencing. They did not want to capture coexisting cancer anymore.
I'll follow up with Kyle.
Sounds good. Did the STS workforce make a decision whether or not to include salvage esophagectomies? Much to my dismay, Heather, they decided to create a subgroup of radiologists of surgeons to uh, make a decision. And I'm pretty sure Leanne heard my deep, deep sigh when that decision was made during that meeting. So we still do not have an answer on salvage esophagectomies. It often takes months for these subgroups to work things like this through. So Leanne and I will try to work it through as quickly as possible. It's just really, really hard to align all of their schedules for meetings, as you can imagine, because I'm sure you all
and I
have a
think,
hard time getting a hold of them too.
yeah, I'm trying to get it scheduled. And I think GTSC is next week, possibly. And I think just about every one of those surgeons are so it's going to take,
Yeah.
working on it. So painful work in progress.
Maybe you should go to that meeting, Leanne, and you can set up like an in-person meeting to discuss over coffee, and that would be the best.
I would like to consider it's in Hawaii this year.
I know. I sadly missed registration and begged to get put on the waiting list. No response so far. Oh, sorry, I'm looking up the answer to Linda's question.
Right.
Mm.
Let's see. I'm trying to see if there's some I can answer while you're. Could I see the 1810 lung cancer slide again? Hold on just a second. Let me get there. 1810. There you go. Emmanuel, there's the 1810 lung cancer slide that you have requested. Okay, 60. I can answer Ashley's for 2460, which we do if we have more than 60 nodes. The database isn't allowing anything greater than 60. I think you can enter the max number.
There was another, yes, coexisting cancer is no longer captured. Agree, Elise. There was a question about, please clarify if there is no SUV max, we put 0. No, if the lesion was not PET avid, then you would enter 0 because the SUV max was 0. If they just failed to report SUV max, then you would leave it blank. What if SUV max is not reported, but only for the mediastinum? The definition of this field is specifically SUV max of the primary lesion. So if the lesion had no SUV max. My guess is going to be that they would want you to leave this blank, but I will confirm that when the core group meets this week on Friday. If you haven't already entered that question, please do. If we have outside CT scans and it triggers a referral and our pulmonologist gets a CT scan and PET EBUS, then places the referral, should I use the outside CT scan that triggered the internal pulmonary consult or the internal CT scan? I would use the outside CT scan that triggered the pulmonary consult, assuming that the sort of normal process for your site or the intended, like the reason for referral was for workup of whatever was originally noted on that outside CT scan, now that they were referred to pulmonary for like sleep apnea or shortness of breath, like, exertional dyspnea or something like that. Now that coexisting cancer is gone, I had a patient with lung and esophageal cancer that had a lobectomy. Esophageal cancer treatment had not yet started. I could not find anywhere to document that they had esophageal cancer. I would think, hang on just a second, I'm looking at the form. Just want to make sure I'm not like totally off base. Sorry, I'm scrolling.
No, you're okay. I'm looking at the question from Callie. Is it possible to add this is for direct data entry. Is it possible to add a checkbox for direct data entry to set all OR dates to the procedure date rather than entering it an additional 6 times? I don't, Callie, can you submit that to the,
Yeah,
but you don't
actually,
know?
I think I know what she's talking about. So, like,
Okay.
you put in surgery date, that's a date field, but then like OR entry is a date and time, OR exit is a date and time, procedure start date is date and time. Um, and everybody wants a button that just fills it all in for them. But there are lots of times when it's not the same date; it's a different date. So we actually do that on purpose. So unfortunately, the answer is no, because if we put a button, everybody uses it, whether it's correct or not, and then we end up with the wrong date and stuff. So,
Thanks, Paul.
yep.
Do you want us to select PET for lung clinical staging, even if greater than 4 months? That is the only way to enter SUV max. And I know the training manual said it didn't matter when PET was ordered in order to enter SUV max. Mm, mm.
Hmm.
That is indeed problematic. Well, we'll have to think about that one. If you haven't already submitted the question, can you submit it, Allison? I'll talk to Leanne offline and see if we can figure out what we're going to do there.
Yeah, I don't understand that one, but yeah, if you could.
The parent to SUV max. So we said capture SUV max regardless of the date that the PET was performed ahead of surgery. But the parent to SUV max has a date cap of 4 months. So we either have to ditch the date cap for the parent or we have to say that we're only collecting SUV max for 4 months prior to surgery.
Okay, I'll take a look at it.
You just have to pick a lane.
Pick a lane.
For 2112 adjuvant therapy given, can you clarify the training manual? Can we only check this if adjuvant therapy is ordered or given within 30 days of discharge? What if the patient has discussed possible adjuvant therapy with the surgeons and has an appointment to see the oncologist just after the 30-day point after discharge? So it says, please indicate if adjuvant therapy is initiated or if adjuvant therapy is scheduled to begin at some future date within 30 days of discharge. For consistency, please do not code based on information provided after 30 days of discharge. So if your patient So in this case, it doesn't look like your patient's adjuvant therapy started within 30 days, nor was it scheduled to start within 30 days. So you would not capture that. Just for the purposes of consistency, like I know it's messy and we just had to sort of draw a line in the sand and stick with it. For hernia patient initially had symptoms including anemia, had a primary repair in June, now had a redo. Would you still report anemia? Additionally, if barium study was done before the initial procedure, but not the redo, would you count that? I mean, I guess if the anemia was ongoing and the reason for the redo repair, I would capture it. If not, I would not capture it. The barium study, I'll have to look and see if we have a date range. My guess is probably not since you're asking the question, but I don't have it memorized. It says within 1 year, code the value closest to the procedure date. So yes, you would capture the barium study. Pathological response sequence 1000. What do we use to code this? The final path from this section or based on pre-OR information? It's going to come from your pathology report from the resection. If a patient discharged, after a patient discharged, a chest x-ray shows pleural effusion, surgeon indicates thoracentesis is needed, but isn't able to be done until after 30 days post-op. Do we still capture? No. If PDL1 CPS score is provided, should we use this score? I'm not familiar with that, Whitney. I assume you've already submitted it. We can talk about that one on Friday too. It'll be a party. History of cancer. It looks like we can only pick that up if patient received chemo or radiation. Yeah, all of the pre-op, like all those coexisting, like all of those were intentionally removed. How do you answer this for cancer types? Cytology and histology demonstrate a poorly differentiated non-small cell carcinoma with bizarre morphology, including giant cells and spindles. The features are compatible with pleomorphic carcinoma. Thought we had addressed pleomorphic carcinomas, but maybe not. Yeah, we did. It says other should be used to capture pleomorphic carcinomas of the lung and lung cancers with presumed histologies listed in pathology reports. That's in the training manual under sequence 2070. For sequence 3070, would you capture flank pain as epigastric or chest pain? No. If there is no MSI, do we leave the field blank instead of unknown or not reported? It is reported, but also does not meet low, intermediate, high. I guess I'll dig into that one. If you haven't already submitted it, please do. Let's see, sequence 24. 62, the manual asks for final pathological staging. Our surgeons do this pre-surgery. Will that suffice, or does it need to be final surgical path?
It says use the final
Pathology report, yeah.
collected during the current surgery.
If the patient had, for SUV max, if the patient had neoadjuvant therapy, do we use SUV max prior to treatment or closest to surgery? The manual now states to use a relevant PET scan. You would use the one prior to surgery, which would be the relevant PET scan. Or prior to treatment. I'm sorry. I apologize. I misspoke. You're going to use the one prior to treatment. Vaping history. In Epic, there is no clarification on vaping status. It's either listed as never used or former.
An Epic.
If documented that patient had prior vaping use with knowing how long ago, do we still capture this as yes? On the data collection form, could it be listed as vaping past or current for smoking history? We can't change the data collection form at this point.
Correct.
So for vaping, it's currently defined as within 30 days prior to admission. If you don't have that information, hopefully you can get that information added. Your surgeon could certainly add that to their pre-op H&P. It doesn't have to just come from Epic, like in the smoking history sequences or fields, I guess. I can clarify on Friday whether they want to capture if there's no date, but historically we haven't gone that route. For sequence 1810, are we assigning clinical stage based on tumor size alone? No, there's a whole graphic in the training manual. There's like the information around how specifically to clinically stage ground glass opacities and mixed density lesions, and then there's the guideline for like this. I don't know if you have the training manual, Leanne, but it's on page 114. So
Yeah, I've got it right here.
There's various things that go into clinical stage. Scroll down.
Yeah, it starts here, and yeah, so just review this information and then
like right there. So like under T2, for example, tumors with any of the following features, greater than 3, invades visceral pleura, invades an adjacent lobe, et cetera, et cetera. On sequence 1800, 1810, if a CT is done at an outside hospital and then done and another is done at our facility, we are to code the tumor size from the outside hospital, even if the tumor is larger and the one closest to surgery. Exactly, yes. I understood that we were to use the size of the tumor from the tipping point. I can't say I have ever seen the T type documented there, so should I leave it blank? No, you're going to have to enter. You're going to have to determine clinical T stage based on the information contained in that report. You are correct. Clinical T stage will never be documented in the radiology report. You might see it documented in your surgeon's note or an oncologist note. What we're saying now is please disregard that and use the information in the training manual to determine clinical T stage for sequence 1810. If MSI is stable, how do we answer? It's a great question. I do not know the answer. So if you have not already dropped in a FAQ, please do. If the patient had visceral pleural invasion, we would code T2A in the current pathological staging, correct? Your pathological stage should come from your pathology report. So we're not changing the way that pathological T, N, and M stage are abstracted. Those should still be coming from your pathology reports. If there's a discrepancy in your pathology report and what you think or pathological T, N, or M should be, please discuss with pathology. Pathological response sequence 1000. Is this per OR path or per imaging prior to OR? This is, so it's the long name is pathological response upon resection. So you're going to take this information from your pathology report. You're indicating the pathologic, yeah, I guess it's in the definition as well. For mediastinal mass, uh, we're collecting thymoma, thymic carcinoma only. Someone advised you can see smoking status by searching social history in the EMR. I assume that's an Epic hot tip, so thank you for sharing that. Going back to clinical T-stage, the current training manual updated in February doesn't state to use the tipping point CT. Correct. That was a March update, and that will post hopefully later today. For sequence 1852 molecular testing, if the testing is ordered during the oncology consultation post-discharge, but the order is to use a tissue specimen from the lobectomy, can I still use? Yes, that's fine. It says from your final addended pathology report, my guess is that they're going to addend your final path report with the results of that molecular testing because the specimen was removed during that surgical resection. So they usually will just throw it on that original path report as an addendum. Do you accept KRAS testing for molecular? I'm not sure what that is, Natalie. I can look into it. Oh, sorry. What is the difference between molecular testing and PD-L1? If we have PD-L1, the molecular testing was performed, but what if we don't have PD-L1 information? So they can test for like various genetic mutations, including this PD-L1%. Mindy says KRAS is molecular testing. Sorry. Sorry, I'm just trying to scroll here.
You're good.
What? So I guess molecular testing is like the total bucket, and PD-L1 is like a specific. Adjuvant therapy 2481 patient is deciding if they want to do adjuvant treatment. Would we leave this blank? Yes, as long as you don't have an answer within 30 days. I mean, the cutoff is very intentionally 30 days so that people aren't obligated to go back and re-abstract these charts over and over and over again. The STS recognizes that we're going to lose some information, but intentionally didn't want to add data collection burden. I think there was a second part of that one that looks like some of the sequences. Maybe it's one off in the training mail. I'll take a look at it, Natalie. Sure, I can do my best to try and email you all back when the STS workforce decides to create like a subgroup. The problem is that when many people submit the same question, it's nearly impossible to go back and find all of the people who asked the same question. So there's no good way for me to find everyone who was waiting to hear back on salvage esophagectomies, unfortunately. And so sometimes topics like that are just covered at the webinar. Another question on 2112. It moved, sorry. Does post-procedure adjuvant therapy have to be given within 30 days of the procedure, or can we count it if they discuss that it's in the plan in the near future? So as long as it's, hang on, I'll go back and read it. Please indicate if adjuvant therapy is initiated within 30 days of discharge, or if adjuvant therapy is scheduled to begin at some future date within 30 days of discharge. For consistency, please do not code based on information provided after 30 days of discharge. So when you go and look at that record at 30 days, if your patient is scheduled for adjuvant treatment 6 weeks from now, you would capture it. Sorry. There are a lot of questions on HER2 new and MSI. I recognize that. I am not an expert on HER2 new and MSI. I will get all of those clarified. The core group meets this week on Friday, and I need the surgeon's brain cells in order to answer everyone's questions on HER2 new and MSI. So I'm just going to move those because I don't have a great answer for you all at this point. And obviously those sequences are new this time around, so I appreciate all of the great questions that you have. My final path report doesn't have pre-op PD-L1 addendum attached. Is it okay to use it off the pre-op EBIS where I do see it reported? I think, let me look at that one with me. Yes. My assumption is that that's fine, Whitney, that you could use PD-L1 from your EBIS, but we'll just clarify again on Friday. Yes, select more aggressive. Is that the same one you would select for preoperative? So the question is for synchronous primaries, if you select the more aggressive from final pathology, is that the same one you would select for preoperative clinical staging? In most instances, yes, but not always, because you don't necessarily know that maybe your larger tumor is going to turn out to be something fairly benign, and the smaller one is something much more aggressive. So they don't have to be the same, but generally they are the same. I apologize. I do have to hop off, Leanne.
That's okay.
I will
No,
continue answering questions as much as I can. I appreciate it.
no, it's fine. Thank you, Ruth. Just for anyone else, if you do have a question, Ruth, I'll get you. You and I can review the questions after the call. I'll get a copy of all the questions that are
Yep.
submitted to the Q&A, and then we can address anything that was not answered that way.
Great.
Thanks for being on today, Ruth, and answering those questions. That was a quick marathon session of answering questions. I appreciate it.
Thank you.
All right. For those of you that would like to stick around, I know since the harvest does close on this Friday, I have a brief harvest close checklist that I wanted to go over. So if you would like to stick around, you're more than welcome. If you do have any additional questions that you wanted to ask Ruth, feel free to put those in the Q&A, and she and I will review those after the call, and answer ones that we can answer or that she can answer, and then bring any questions to the core group this week and surgeons later on this week.
Leanne, before you get off the Q&A, there's like the first question is direct data entry. We'll go over on its own. I'm assuming what they mean is you don't have to submit data if you're doing direct data entry, and that is correct.
Yeah.
And just
it's my first bullet point.
Oh, okay. Oh, I'm sorry.
That's all right. But you're still my thunder, Paul.
Oh, sorry.
That's all right.
Yeah, but actually, one thing to keep in mind is depending upon the way that your IQVIA account has been set up, if you're direct data entry, you may even see the upload button there, but don't use it. You could really hose up your data if you use it. If you're doing direct data entry, just enter it. And every time you save the record, it's actually already submitted. Then you don't have to worry about it after that. So,
All right. Thanks, Paul.
yep.
All right. So again, for those of you that wanted to stick around, I created a couple of slides with a quick harvest close checklist. I know, I love a checklist, especially when harvest close comes along. So for our near data managers or seasoned data managers, hopefully that you'll find this helpful. So again, as Paul stated, if using third-party vendor software, you upload your data to the data warehouse. Last day to do that is this Friday by 11:59 p.m. Eastern time. And then, Paul just gave some info about direct data entry. You should not upload files for harvest submission if you are a direct data entry site entering your data directly into that QBO platform. Once you have successfully uploaded or entered your data for direct data entry sites into the platform, first thing that you'll want to do is review your data quality report. It's important to note that the data quality report is specific to the file that you submit. So if you submit one file with 1 year's worth of data, that data quality report is specific to that one file, with that 1 year of data. If you submit a file with 3 years worth of data, that data quality report is specific to that file with those 3 years. So review your data quality report. First and foremost, resolve all critical errors if they are encountered. It's important to note that if any critical errors are not resolved, those records will not be saved to the data warehouse and they will not be included and utilized in analysis. Again, just review critical errors, warnings. They are all specific to that file that was submitted. If you do have critical errors, you can you can utilize your critical summary report that's located on the tab right next to your data quality report at the bottom of the screen. So you can review your critical summary report. When you are looking at your critical summary report, the dates that need to be submitted are the dates for the data file submission. So you're not entering surgical date ranges. You are entering dates for the times that you submitted data files. So you could look at February 1st through March 11th, 2026. So that'll give you a critical summary report for all the files that were submitted during that date range. So again, critical summary report utilizes the date of files submitted, and you can use this report to review upload submissions to determine number of records that were uploaded successfully. And then you can also utilize this report to determine a surgical date range included in the upload submissions. After your critical summary report, take a look and review your harvest summary report. So as opposed to the critical summary report, your harvest summary report, you will enter surgery dates to review the report results. So if you want to look at the entire, you've submitted multiple files with 1 year in each file. If you want to look at it as a whole in one viewing, use that harvest summary report and enter the surgery date. So you can look at January 1, 2023 through December 31st of 2025, and you can review all of your critical errors and warnings in one report. So you can utilize the harvest summary report to review everything as a whole, as for the whole analytical period. You can also do it 1 year at a time. Just depends on how you want to review your data. Also, take a look and review the missing variable report. Similar to the harvest summary report, you'll use surgery date ranges to review report results. And when you're reviewing your missing variable report, you can utilize the risk model variable filter, procedure type, procedure class to prioritize your data cleanup. I always suggest starting with your risk model variable, your procedure type, And then procedure class, we're looking at major versus minor procedures. So obviously you want to look at those major procedures. After you have reviewed your data quality report, protocol summary report, harvest summary report, missing variable report, the last thing that you do, if you've done all of your data cleanup, the last thing that I suggest that you do is review the community page for the current harvest missing unknown summary. As many of you know, there is a participant-specific exclusion for participant-specific exclude. Oh, hold on, sorry. Lost my slide here for a second. There is a participant-specific level threshold for operative mortality. So in order to be included, that should say spring 26. So I will correct that slide. That should say spring 26. So oh goodness. So in order to be included in the spring 26 harvest analysis, which includes I missed everything. This forgot to this should include ORA dates from January 1, 2023 to 12/31/2025. You must have 2% or less missing for the mortality fields. So, and this is for, we look at this by each individual year. So for 2023, you must have 2% or less missing unknown for the mortality. Same for 2024, 2025, 2% or less missing unknown for each individual year. It's not 3 years as a whole, it's each individual year. As we talked about during our GTSD office hour session yesterday, it's important. Many participants have gotten tripped up on the status at 30 days after surgery. So if MT30 stat is coded as unknown, this will be counted as missing data when calculating your 2% missingness threshold. So please remember that. I just included a snapshot here of a participant's current harvest missing unknown summary. As you can see, everything looks good. Everything's in the green. They have 2 records for 2025 that have a missing or unknowns, and that puts their percent missing at 1.23. I would recommend, since this, it's close to 2%, this number eligible, it's not exact. It's not the exact same number. It could potentially not be the exact same number of records eligible for analysis due to additional exclusions, things that happen over on the analytical side. But if you see yourself getting close to 2%, I would go back and review any records that have a missing or unknown status, just to be sure. So again, just use this as your last step before you end up signing off or saying you don't want to do, you're done with your harvest. Just review any missing or unknowns. If you're close to that 2%, these numbers are an estimate. We get them as close as possible, but it is not an exact number. So just keep that in mind. Hopefully, I know that was a super quick harvest close checklist, but
And Leanne?
yeah.
Yeah, can I jump in with something that I
Sure.
came up with over the past week or two? I've got a couple of sites that came across this issue for people using vendor software and uploading their files. When you upload a file and you submit a brand new record, it tells you whether there's any issues with the data. If you get a critical error, you can think of that as the whole record being kicked out. So we don't have that record, so you really need to resubmit that data. If you get just errors, it might tell you that this field is missing a value, and you should provide it, but the record still gets accepted into the database. The problem that we ran into is that we had some sites then resubmit the same data again. When you resubmit the same data again, one of the first things the system does is checks to see, do we already have that record and has anything changed? And if we already have that record and nothing has changed, all you get is a message saying that record's exactly like what we have. Record was ignored. Okay. So in your data quality report, if you look at the second submission, it may look like there's no problems, but you still have that problem of the data being missing or data values out of range, or there's some other issue. So it's really important that you do look at all of these other reports, not just your data quality report. Look at your missing variable report, your harvest, your critical summary report. You really have to look at everything to make sure that your data is all set. So I just wanted to point that out. It's kind of a strange quirk, but it tripped up a couple of people with this harvest.
Yep. Paul, quick question.
Mhm.
Is there, because I don't use direct data, I'm not as familiar with direct data entry. Is
Mhm.
there a critical summary report for direct data entry? I don't think there is.
Not a not a harvest summary.
A critical summary report for direct data
Summary
entry.
report. I don't think so, because that's only with the upload. You
Right.
get to that through your
Upload.
uploads.
Right. Correct. Yeah.
Yeah, so I think that's probably true. Yep.
Yeah. So Natalie, if you are a direct data entry site, you would not have a critical summary report. But if you are a site that hold on, I had this up. If you are a site that uses a third party vendor, hold on, 402, let me look for, you upload from a third, okay, hold on, I had it open, but I timed out. Hold on just a second and I'll show you. I'll pull it over here in just a second. I want to make sure I'm not showing participant specific identifier. Da, da, da. Sorry. Da, da, da. Okay. So yeah. All right, Natalie. So I've pulled over a site. Um, Here is, I pulled over their data quality report. So here you can see the DQR, and then here's the tab for DQR, and then here's the tab for critical summary report. And then here's when you would put in the date ranges for the files that were submitted. So you could use February 1, 2026 through 3 um, up to 3/11/2026, and you would see all the submit. You get a submission summary for all the files that were submitted, the first surgery date in the file, last surgery date in the file. So you could, how
Mhm.
did I get to the DQR? You go to, hold on, you go to, um, this has got, so when you go to your upload, let me see if I can do this. I don't want to, hold on.
Yeah, you can't really show this
I
the
can't,
screens, but
yeah.
yeah, it just when you do the upload, you'll get the screen that shows what files you upload, the name of the file, and the status of it. There's a button on there for view reports. You click on that button, that brings you
Oh,
to
she
the
found
data
it.
quality report. Yeah. Okay.
Perfect.
Okay.
And you abstractor here in IQVIA, will I be able to easily find all of these reports I need to review? We use ARMIS and upload into IQVIA. Yes, you will be able to easily locate these reports.
They're they're all under operational reports.
Right.
Yeah. Yeah.
I'm trying to pull up. It's so hard not, I don't have a test site, so or dummy site, so it's hard for me to pull up and not share participant specific data. I'm trying. Hold on. I have too many screens open. Okay. But if you new abstractor, if you do have questions, if you get out that you upload your file and you have questions, just email the help desk. And Paul and Banu or myself, we're happy to meet with you and walk through. I know you're new, and if this is your first time submitting data, just reach out to the help desk and we can help you review any of your reports, or just help you through your first harvest. More than happy to do that. How many outreach attempts are required for 30-day, 1 year follow-up? As many for 30-day, as many as you can, as many as you can possibly find until you get that 30-day status. Truly, in some situations, they are unknown. Like that person has disappeared off the planet Earth, and there is absolutely, you have done everything in your willpower to find the status of this person. You have called everyone, you've called every other, they went to another hospital, you've called primary, whatever. Checked national death index. I have no idea, but use any means possible to find the status of that person. Um,
That should be a rare occurrence, and
yeah,
that's
yeah,
why you have a 2% threshold is, to catch those individuals where you tried your best and this person is in the witness protection
yeah.
program or something. You just can't find the person. So there is a little leadway, but that should be a rare condition and that should not put you over the 2%.
It just gets really, if you just have a small n, that's when it gets a little tricky.
Yeah. Mhm.
Okay, so do we really need the community page if it can cause confusion? I don't know. What do you mean it can
Yeah,
cause?
Yeah, well,
the community pages, that information, that's like the first thing that's going to raise the flag to say you're not getting an analysis.
Yeah.
So yeah, I would look at that. That's direct data entry and upload people. That's a critical thing to look at.
yeah, you have other reports to see all the detailed
Mhm.
information that you need to see after an upload, but it's good to be able to see everything in your data
Mhm.
for a certain period of time and to be able to identify what to look for.
Yeah.
Yeah, you might your data may not be included in some certain part of the analysis, and you might get a
Yeah,
dash in there for that, like that. But what's on the community page, that's going to kick you out of the whole report. You're not getting a report at all.
yeah.
So that's critical. You want to make sure that that's right.
Yeah. All right, thanks, Paul. Um, let's see. Um, okay. Kyle, you missed the answer to your question. If you can, Kyle, email me directly because I need it with your participant ID number, so I can take a look at your data, since you are covering for a coworker. Make sure that you're getting everything in that you need to based upon your colleague's previous submission. You
Um,
can. Oh, go
yeah,
ahead.
and now I read that question
Okay.
differently.
Okay.
Basically, what's required is to send the we do half year harvests. So like the new data that we're getting is 6 months worth of data. So you want at least the past 2 quarters. We recommend that you submit at least the past year's worth of data because the prior 6 months of data, you may have had patients who had an extended length of stay. And now, when the last harvest happened, you didn't have the discharge date because they were still in the hospital, or you didn't have the mortality information because they were still alive. So you'll be surprised how much of your really old data gets updated. So I would submit at least a year's worth of data, and uh, a minimum of the past 6 months because that's going to be all new data. But we would go back at least a year. That's the way I read that question. Maybe I'm
Okay.
reading it
Yeah.
wrong, but yeah, that was my thought.
Oh, no worries. All right. We are about 11 minutes after. Oh, Kyle said he'll submit the year. Thank you. Oh, Anita, so what's the point in combining the lung and esophageal missing unknown? That's what causes confusion when looking at the 2% threshold. So the point of combining those two populations together is because the N is so small for, can be small for some of our participants. For example, we may have a site that does, um, you know, 15 lung cancer and one esophageal. You can't look at each individual um, composite population. We combine them because the N can be so small, and many, many, many participants would get excluded for missing potentially one 30-day status. So that's why we combine those populations together. So the 2% missingness threshold is based upon both composite populations and not just each individual population. Uh, let's see. Wait, I saw a question. Did I dismiss it by mistake? Oh, I think I dismissed it by, hold on. let's see, sorry. Where it states eligible on this current harvest missing unknown summary on community page. Why is that number not matching my participant summary data when narrowed down to lung and esophageal cancer cases for each of those individual year numbers? So I think it has to do with the different exclusions that happen in the reports. Whitney, if you could just submit that to the help desk and we could take a look at it. Okay. All right. I think, all right. All right. Trying to understand. Okay. No problem. All right. Thanks, Whitney. Could you walk me through how I can get to the critical report? Where's the critical summary report? I don't see it in the operational reports listing in white IQVIA. Okay, hold on just a second. So if you'll see the critical summary report, if you use a third-party vendor, let me see something really quickly. And it's on the DQR page. Hold on. I just found this. Okay. Why is it doing this? I'll just get rid of that. Okay. Upload. Oh, so from your uploader screen, you have your file uploads, you have view reports. So click view reports for this is each file that you uploaded. So you have, again, you have an individual data quality report for each file that you upload. So click on view reports. And this will bring up the data quality report for that file that was submitted, hopefully. There we go. So here's the data quality report for that specific file. Here you see down at the bottom of the screen, here's your DQR, and then here is the tab for the critical summary. So hopefully that helped. Does that help, Valencia?
Yeah, you can think of the critical summary report as like a summary of your data quality reports. So, the problems that you had on records for multiple uploads, that's where you're going to find that kind of information.
Perfect. Alrighty. All right, I think that's good. We're about almost, yeah, we're 3:46. So let's go ahead and end it for today. Sorry for the angry scrolling, guys. Next webinars, our next upcoming monthly webinar is April the 8th. At 2:30 Eastern, 1:30 Central, and then our May webinar is scheduled for the 13th. And then our next quality improvement series webinar is scheduled. We moved these from monthly to quarterly. So our next one is scheduled for June 25th at 3 Eastern and October 29th at 3 Eastern. So be sure to check out our next monthly webinars. So, and 21, the 2% is based on the combination of the two per year and not individual case. Yeah, so Anita, if you continue to have questions or confusion, please just feel free to shoot me an email. And if you just want to talk it through, I can talk it through with you a little bit more if you're still confused. So you have the 280 lung cases in 21. So those are your total number of cases. The 2% is based on a combination. Yes, so those two eligible added together of the per year and not the individual case types. Yeah, so it's the total number of your lung and esophageal composite records that are eligible for the composite. Those two totals ends are combined, and then we're looking at the threshold for each individual year. All right, cool. Yes, perfect. Yeah, and like I said, if you have additional questions, just feel free to reach out. Happy to help. All right, everyone. Thanks for hanging in there today. Hopefully you found today's webinar, the harvest cleanup, harvest closure stuff, a little helpful. If you have questions, please reach out to me directly. Happy to address any harvest close questions, as well as reach out to the help desk, Paul and Banu. Between the three of us, we can help you get things wrapped up. With that, I hope you guys have a great rest of your day, and we will see you on our next webinar. So happy harvesting, and just a reminder not to wait till Friday to get that last file in. Thanks, everybody. Thanks,
Thanks.
Paul, Bonnie, and everybody. I
All
appreciate
right.
it. All right, bye-bye.
Bye.
Bye.